Hello, my name is Krutika Mediwala, and I'm an infectious diseases antimicrobial stewardship clinical pharmacy specialist at MUFC Health in Charleston, South Carolina. Today, I'll be discussing the evidence surrounding Lopinavir Ritonavir as a potential therapeutic option in COVID-19. This agent is available as a generic, but for simplicity, I will refer to it as Kaletra in this presentation. Kaletra is an antiviral agent for HIV, including post-exposure prophylaxis. It works by inhibiting the HIV-1 protease, leading to the formation of immature, non-infectious viral particles. It is rarely utilized in HIV in the setting of one-pill regimens and increased safety and efficacy with integrase inhibitor combinations. In SARS coronavirus, the main protease is known as chymotrypsin-like protease or 3CL protease. It is hypothesized that Kaletra may inhibit this protease, leading to similar results as HIV. The ritonavir component inhibits CYP3A4 metabolism of lopinavir, therefore leading to increased serum levels. For drug monitoring, the optimal peak is at 9.6 micrograms per ml and trough is at 5.5 micrograms per ml. Looking at the dosing for Kaletra, it's largely been extrapolated from HIV therapy, as no current evidence exists on the optimal dose for SARS-CoV-2. It is dosed at 400 mg Lopinavir and 100 mg Ritonavir by mouth twice daily. No renal adjustments are necessary, and caution should be practiced with hepatic impairment as AUC increases up to 30% have been seen. Crushing and administering tablets via a gastric tube may decrease absorption by 50%. Increased doses might be considered in this situation. There is some in vitro data for Kaletra in SARS-CoV-1. SARS-CoV-2 shares about 80% sequence identity with SARS-CoV-1. Therefore, evidence for its use in that and MERS was used as a basis for experimentation. Some positives include molecular simulations showed that Kaletra may inhibit key enzyme and its activity was seen up to 48 hours. When combined with ritonavir, cytopathic activity was seen at much lower doses. However, the EC50, which is the 50% effective concentration, was 17.1 and 50 micromoles in two different studies. The CC50, which is the cytotoxic concentration, was over 32, with a selectivity index of greater than 2. The selectivity index is the EC50 divided by the CC50. For reference, the EC50 in HIV patients ranges between 8 to 24 micromoles. The binding site analysis showed that there was a possibility that one half of the lopinavir was actually left outside of the cell, leading to poor efficacy. Furthermore, other conflicting studies showed that Kaletra may not have any effect on the replication of SARS-CoV at all. There's also in vitro data available in MERS-CoV. In comparison, lower concentrations of Kaletra are needed for inhibition of MERS-CoV replication. Lopinavir was shown to inhibit MERS-CoV replication with EC50s of about 8 micromoles, which is in the range of the Lopinavir concentrations in HIV patients. In contrast, another study showed that Lopinavir was not effective in initial cytopathic effect assay, and the EC50 value was 11.6 with no significant enhancement for ritonavir. In vitro data for SARS-CoV-2 is still lacking, but there is updated human data that I will discuss later in this presentation. There's no animal data in SARS-CoV, but there is animal data available in MERS-CoV. Chan and colleagues studied the effect of 3 potential therapies for MERS-CoV in primates. These included mycophenolate, Kaletra, and interferon beta. The animals were observed twice daily for clinical signs and scored using a clinical scoring system, which included evaluation of general appearance, skin and fur appearance, any discharge, respiratory rate, and food consumption. The untreated group had increased respiratory rate and reduced movement, loss of appetite, hypothermia, a higher mean clinical score, as well as extensive multilobular hemorrhagic lung lesions and infiltrates. The mycophenolate group saw increased respiratory rate, reduced movement, loss of appetite, hypothermia, higher mean clinical scores, and extensive multilobular hemorrhagic lung lesions and infiltrates. And this was actually highest, the mean viral load in lungs was highest in the mycophenolate group. In the Kaletra and interferon beta groups, though the Kaletra treated and interferon beta treated animals had better outcomes than the untreated animals. There were no severe symptoms, and this group actually saw less weight reduction. They had improved mean clinical scores, less pulmonary infiltrates, and the Kaletra group had the lowest mean viral loads in lung. It is important to note that the study did not evaluate the effects of combination treatment with 2 or more drugs due to the difficulty in getting approval for using more primates. Sheehan and colleagues studied transgenic mice with humanized MERS-CoV receptor. They studied remdesivir alone, then Kaletra and interferon beta alone, then in combination with all of the agents in some form or another for treatment and prophylaxis. Kaletra actually had minimal effect when used as prophylaxis. And the interferon beta activity was improved when combined with Kaletra. These data suggest that the observed in vitro antiviral activity of Kaletra and interferon beta combination on MERS-CoV is dominated by interferon when Kaletra is used at clinically relevant concentrations. Looking at the remdesivir group, they saw low EC50s and great selectivity index. They also saw diminished viral replication and disease, reduced acute lung injury, and this was sustained when combined, pointing to monotherapy benefits for remdesivir alone. Kaletra was studied in a retrospective matched cohort in patients with probable SARS. The aim of this study was to analyze retrospectively the outcomes of patients with SARS treated with Kaletra compared with a matched cohort who received standard treatment only. All patients received ribavirin at the dose listed for 14 days and a decreasing regimen of steroids for 21 days. 44 patients also received Kaletra for 14 days as initial therapy versus 31 patients who received Kaletra for 14 days as rescue therapy after failure of standard treatment. Patients were matched based on sex, age, comorbidities, and LDH. (91% had PCR-positive SARS. Treatment started a median of 5.5 days after symptom onset and 1 day after ribavirin. Patients in the initial therapy group had significantly lower rate of intubation and death. There were also less patients requiring pulse steroid rescue, and when they did, the mean doses were significantly lower. No significant increases in drug toxicity, such as refined as 3 times ALT increase or serum amylase increase, were seen. In terms of rescue treatment, 96% had PCR-positive SARS. The treatment started a median of 18 days after symptom onset and did not overlap with ribavirin treatment. The outcomes in the rescue group were comparable. Interestingly, mean pulse steroid dose was higher in the rescue group. Again, no significant increases in drug toxicity or serum amylase increases were seen. It is also noteworthy that patients who received Kaletra as a rescue treatment received higher doses of pulse corticosteroids, suggesting that the physicians had selected patients for Kaletra rescue therapy who were in poorer clinical condition. This might have masked any possible benefits of Kaletra treatment. Any benefit from synergism between the 2 antiviral agents might also have been eliminated in the rescue treatment group, since ribavirin was already discontinued when Kaletra was added. Limitations of this study include the retrospective nature, comorbidities not classified by severity, sicker patients in the rescue therapy group, as well as the study did not concentrate on ribavirin and steroids and if they were effective. Both groups had ribavirin and steroid therapy available. Chu and colleagues performed an open-label, non-randomized study in probable SARS patients receiving ribavirin and steroids. The historical controls did not have any Kaletra added versus 41 patients who received Kaletra for 14 days. The primary outcome measure was a composite adverse outcome at 21 days, which was defined as severe ARDS or death. Clinical measurements and blood tests were performed daily. As far as outcomes go, the development of ARDS and death within 21 days occurred in significantly less patients compared to the control, and you can see the breakdown in the table listed on the slide. When looking at changes in viral load, Lopinavir showed in vitro antiviral activity against SARS at concentration of 4 micrograms per ml. However, when combined with ribavirin, Lopinavir appeared considerably more effective with an inhibitory concentration of 1 micrograms per ml. Again, for reference, the peak and trough serum concentrations of Lopinavir were 10 and 5.5 respectively. Park and colleagues performed a retrospective matched cohort for PEP in healthcare workers with high-risk exposure to a MERS-CoV pre-isolation patient. The objective was to assess for safety and efficacy of this regimen. Patients were divided into PEP, which was ribavirin and Kaletra times 14 days, or no PEP at all. Lab testing for healthcare workers in the PEP group was performed on days 3, 7, and 11 after treatment initiation. Healthcare workers who received PEP therapy also underwent 2-point sputum screening with MERS-CoV respiratory PCR. PEP therapy was associated with a 40% decrease in risk of infection. Although 96% of PEP patients had adverse drug events, none were classified as severe. Talk about the rapid evolving data and evidence with COVID-19. This article was one of the first published studies related to COVID-19 in Kaletra. Cow and colleagues performed an open-label, individually randomized study in patients with PCR-positive COVID-19 infection. Groups were divided into standard care, listed for you on the right side of the slide, and Kaletra for 14 days, versus those with just standard care alone. The primary endpoint was the time to clinical improvement, defined as time from randomization to either an improvement of 2 points on a 7-category ordinal scale or discharge from the hospital, whichever came first. Looking at the outcomes, first and foremost, it is important to note that median interval time between symptom onset and randomization was 13 days. Approximately 33% of patients received steroids and 11% received interferons. There were no differences in time to clinical improvement or mortality in the intention to treat group. In the modified intention to treat group, the Kaletra group was associated with numerically lower mortality. No differences in clinical improvement at 14 days was seen between both groups. Overall mortality was pretty high at 22%, which was more than other trials, denoting the severity of illness in these patients. In terms of decrease in viral loads, there was no difference between the Kaletra and the control groups. The authors concluded that Kaletra added to standard treatment was not associated with better clinical outcomes or mortality in severely ill patients. There was no difference in decrease in viral loads over time. It is important to note that in this small patient population, benefits in the Kaletra group were numerically higher, especially in the post-hoc groups. Looking at adverse drug events, almost 50% in both groups reported adverse drug events, specifically nausea, vomiting, and diarrhea. Approximately 14% of this was in the Kaletra group, and they could not actually finish therapy due to the severity of these ADEs. Speaking of ADEs, it is important to consider serious adverse effects that Kaletra has. These can include hypersensitivity reaction, angioedema, Stevens-Johnson, toxic epidermal necrolysis, or TEN, QT prolongation in torsades, AV block or PR prolongation, hyperglycemia, hypertriglyceridemia, renal failure, anemia, leukopenia, neutropenia, hepatotoxicity, nausea, vomiting, diarrhea, insomnia, anxiety, and these are actually contraindicated in cardiac disease and liver disease. Ritonavir being a CYP3A4 inhibitor, we have to keep in mind other HIV and HCV agents that may have drug-drug interactions with this agent. These can include antifungals, amiodarone, apixaban, tacrolimus, and agents in psychiatric illness. Looking at drug-food interactions, the oral solution has increased levels if taken with a high-fat meal, potentiating some of the common adverse drug events. The tablets can be taken with or without food. So what's the evidence for COVID-19? Currently, there are no reported U.S. studies available for Kaletra. The New England Journal article I previously mentioned showed no benefit in adult hospitalized patients. This has essentially led many institutions to disregard the role of Kaletra in COVID-19 treatment. Another study was published in the Lancet Journal earlier in May, which I will discuss as an update. There is conflicting evidence in terms of SARS-CoV-1 and MERS-CoV. Some studies have shown improvement in symptoms and reduction in viral load. The Chinese COVID-19 treatment guidelines do list Kaletra as a recommended antiviral regimen, and there may be a potential role of Kaletra in pregnant patients, but again, we are lacking data. And safety is a huge concern. These adverse drug events are what are leading to discontinuation in a lot of patient therapies. As an update, this study was published in May of 2020 in the Lancet Journal. Hung and colleagues performed a phase 2 multi-center open-label randomized trial with SARS-CoV-2 PCR positive patients. Patients were enrolled in the combination arm, which contained Kaletra, ribavirin, please note the lower dose, and interferon beta for 14 days. Within this group, patients were then divided into less than 7 days of therapy where they did get interferon, and greater than or equal to 7 days where interferon was omitted to avoid its pro-inflammatory effects. The control arm contained patients who were given just Kaletra, and both arms received standard of care, which is listed again for you on the slide. The median time to hospital admission from symptom onset was 5 days. Baseline characteristics were similar amongst each group, but it is important to point out that fever and unproductive cough were the most common symptoms. Majority of the patients had abnormal chest X-ray, lymphopenia, mildly elevated CRP, and ESR rates. Another important point is that the public health ordinance in Hong Kong required all patients tested positive for COVID-19 be admitted to the hospital and stay until the nasopharyngeal swab viral loads were negative for 2 consecutive days. This is important to consider looking at these baseline characteristics because these patients may not all meet inpatient criteria, especially here in the United States. The primary endpoint was time to achieve a negative RT-PCR result for SARS-CoV-2 in a nasopharyngeal swab sample. Secondary clinical endpoints were time to resolution of symptoms defined as a NEWS2 score of 0, maintained for 24 hours, a daily NEWS2 and a SOFA score, length of hospital stay, and 30-day mortality. They also measured other virological endpoints that also included a negative SARS-CoV PCR in all clinical samples. The NEWS2 stands for National Early Warning Score, which includes respiratory rate, oxygen saturation, pulse, blood pressure, temperature, and consciousness. Safety endpoints were the frequencies and duration of adverse events. As seen here, triple therapy was significantly superior in terms of primary outcome. Time to sustained NEWS2 and SOFA score of 0, length of stay, and time to negative PCR in all samples are significantly reduced in the combination therapy arm. There are some important things to take note of. The 30-day mortality was not different between the two groups. Neither was oxygen therapy or ventilatory support. So if we're really looking at aspects to be improved with this cumbersome regimen in mild to moderate COVID-19 illness, how beneficial is this regimen? The authors also broke down the outcomes based on when the treatment was started, less than 7 days or greater than or equal to 7 days. Most of the statistically significant benefit was seen in early therapy, especially in the NEWS2 and SOFA changes, as well as time to negative viral loads. However, taking a closer look at those breakdowns in the tables provided, these were either 0 or very low to begin with. These values were higher later on, that is later than 7 days, which questions the true role of Kaletra in the combination regimen. The IL-6 concentration in the combination group was significantly lower than in the control group on days 2, 6, and 8. The authors concluded that early triple therapy with Kaletra, interferon beta, and ribavirin treatment effectively suppressed viral load in all clinical specimens in IL-6. Combination therapy was associated with significantly shorter time to alleviation of symptom and shorter hospital stays. Serious adverse drug events were similar in both groups with minimal discontinuation. The skepticism starts with the baseline characteristics. The SOFA and NEWS2 scores were not indicative of severe illnesses and may not have warranted admission if not required per Hong Kong rules. There were no statistically significant differences in the 30-day mortality, oxygen requirement, and need for ventilatory support. ADEs and secondary antibiotics were reported in almost half of the patient population, which hurts my antimicrobial stewardship heart just a little bit. So in summary, there is still conflicting evidence in related viruses such as MERS and SARS-CoV-1 for the use of Kaletra. The most recent randomized studies for COVID-19 suggest either no benefit or benefit with early combination therapy, but we have to read between the lines and take a closer look at that patient population. The availability, and this is pretty important as we're currently unable to get Kaletra in stock on a regular basis. Most studies have been performed in combination with ribavirin or interferon, which are not the normal treatment route we go with in the United States. And lastly, the safety profile. The primary reasons for reduced use in HIV are also similar here. Additionally, with the use of combination therapy with ribavirin and interferon, we're just going to have a lot more adverse drug events. So this concludes my presentation on the use of Kaletra as a potential therapeutic option for COVID-19 as part of the Society of Infectious Diseases Pharmacists COVID-19 response. Thank you so much for listening.